Okay, now let's talk about non-invasive respiratory monitoring. So these are things that are going to be on the outside of the body. These are tools, and and remember, these are tools. So they're to be used, but they are not to replace a good solid auscultation, visual, and tactile or palpation type assessment. Um, so several available devices will help measure the effectiveness of oxygenation and ventilation and maintain the parameters at those appropriate levels. Those measurements, most commonly in the pre-hospital care, are pulse oximetry or SaO2, end tidal or CO oximetry, and capnography. So CO oximetry is very similar to a pulse ox. However, it will measure additional gases in the through the fingertip probe, much like a pulse ox does. And then capnography is end-tidal CO2 that is read through either a nasal cannula or a adapter onto an ET tube. Peak expiratory flow testing can be also useful in the pre-hospital setting for some respiratory diseases, although it's not widely employed because those are a one-time use, disposable type thing, and most services are not using those. Some may. I have not run across any in my experience. However, um, the respiratory therapist can usually take care of that in the ER once they get there. These measurements use various devices and methodologies that, when used alone, have their limitations. However, when used together, they can provide a very comprehensive and reliable picture of the patient's respiratory status. So, if we look at the next, um, when we look at the next table, we'll see how they will work, how they can work together. Um, But when we talk about pulse oximetry, we're talking about often refer to it as a fifth vital sign. Everybody wants to know what the pulse ox is. A pulse oximeter measures the hemoglobin oxygen saturation in peripheral tissues. So that's why it's on the fingers, on the earlobes. You may see them on the nose, the feet on infants or toes on toddlers. It is non-invasive. It's a sensor that sits on the skin and shines through and reads on the opposite side of whatever appendage it happens to be on, whether it be a finger, ear, nose, or toes. But it has to be a fairly thin in relation, so like you couldn't put it on an arm and read through the other side. The sensors aren't that big and they're not that powerful. Um, it is rapidly applied. It does not require entering the body, thus non-invasive, and easy to operate. You turn it on, you put it on, make sure there isn't a break in the cord or the sensor, and make sure the light's on, and it should be reading fairly accurately. The readings are generally accurate and measure of arterial oxygen saturation and continually reflect any changes in peripheral oxygen delivery. Um, in fact, pulse ox detects problems with oxygenation faster than assessment of blood pressure, pulse, and respirations, because you're getting it before it hits those peripheral tissues and endpoints. When available, you should use it in virtually any situation to determine a patient's baseline value to guide your care and to monitor the patient's response to your intervention. So if you're doing something good, you should see an improvement, either a lowering of the pulse rate or an increase in the O2 saturation, are the main two things. Or if they're further beyond where they've entered into bradycardia, then you want to see an increase in heart rate and an increase in SaO2. To determine the peripheral oxygen saturation, you place a sensor or probe over a peripheral capillary bed, such as a fingertip, toe, earlobe. You can wrap it around the foot in infants. They're usually secured with tape on infants and kids. Some sensors are taped onto fingers, even on adults. There's two light-emitting diodes and two sensors. One emits a near red light at a wavelength specific for oxygenated hemoglobin, and the other one emits an infrared light, which is specific for deoxygenated hemoglobin. Each hemoglobin state absorbs a certain amount of emitted light, preventing it from reaching the corresponding sensor. Less light reaching the sensor, that means more of its type of hemoglobin is in the blood. The oximeter that calculates the ratio of the near red and infrared light it has received to determine what the oxygen saturation percentage is. So if the percentage is higher of oxygenated blood than deoxygenated blood, then your SaO2 is going to be a higher percentage. If it is lower, then it will be a lower percentage. They display the SpO2 and the pulse rate detected by the sensors. They show either as a number or as a visual display, also shows the pulses, waveform, and heart rate. The latter helps you to ensure that the reading is based on good data. So if your pulses match, so this requires a little bit of work from you. So you're going to check a pulse. You're going to match that pulse to the pulse oximeter to make sure that it is reading accurately. Just because you've got a good number on the O2 saturation and you've got a poor number, but your pulse does not match, that indicates an inaccuracy. And then, further based on your patient assessment may show that the pulse oximetry is not working for whatever reason. If the patient's pulse is 120, but the pulse oximetry waveform is detecting only 60, or the waveform is nearly flat, then the reading is unlikely accurate, as we discussed. The relationship between the SpO2 and the partial pressure of oxygen in the blood is very complex. However, the SpO2 does correlate with PaO2. The greater the PaO2, the greater will be the oxygen saturation. Because hemoglobin carries 98% of the oxygen in the blood, whereas plasma carries only 2%. Pulse oximetry accurately analyzes peripheral oxygen delivery. So it's going to let us know what's reaching the periphery pretty accurately. As a guide, normal SpO2 varies between 96 and 99% at sea level. Readings between 91 and 95 indicate mild hypoxemia and warrant further evaluation and supplemental oxygen administration. Readings between 86 and 90% indicate moderate hypoxemia. You should generally give these patients high concentration supplemental oxygen using a non-rebreather. Reading of 85% or lower indicates severe hypoxemia and warrant immediate intervention, including administration of high concentration oxygen, ventilatory assistance, or CPAP. And we'll discuss CPAP later. Your goal is to maintain an SpO2 in the normal range. So, as we discussed, here's the table showing how pulse oximetry, what it reads. It reads oxygen. It checks for oxygenation. Pretty simple. Reflects changes in oxygenation in less than 5 minutes, up to 5 minutes, and longer in cold extremities. Just know that in extreme cold temperatures, your SaO2 or your SpO2, your pulse oximetry is going to be inaccurate, most likely, because of the vasoconstriction due to the cold. Delayed detection of hypoventilation or apnea, because you've got that delay from gas exchange in the lungs to oxygenation at the periphery. It takes a little bit to get there. This should be used with capnography, and we'll discuss capnography further here in a little bit. The capnography measures carbon dioxide. It is measured during ventilation. It is usually in a nasal cannula format or in an adapter for the ET tube. Reflects changes in ventilation in less than 10 seconds. This immediate detection of hypoventilation and apnea, and it should be used with pulse oximetry. So basically what this is giving you a breath by breath reflection of ventilation. So every breath it's going to change and give you a pretty accurate reading. And it's going to be immediate. Whereas this is going to show, pulse oximetry is going to show you the effects once that reaches the periphery. Here's our pulse oximeter. Let's see if it shows our video. It may or may not. So there you see the little red light. Oh, I apologize. This does not work that way. This is doing something else. I apologize. That's okay. We can do that later. We know what a pulse oximeter is, and we know how to use it. So as we're going on, we're discussing oxygen administration. One of the things that we're going to run into is how much is too much, how much is not enough. Recent studies show that oxygen administration is not without risk. Excess oxygen can cause the body to manufacture toxic chemicals called free radicals. And we'll discuss that in patho. These toxic chemicals can damage the body tissues, especially in the areas of highly oxygen dependent, such as the brain and heart. Because of this, oxygen should be administered only to patients who are found to be hypoxic by pulse oximetry. Then only enough supplemental oxygen should be administered to correct that hypoxemia and restore normoxia, or normal oxygen range. Trying to fully saturate hemoglobin with oxygen can cause the formation of the free radicals and result in what's called as oxidative stress. The excess concentrations of oxygen, or hyperoxia, should be avoided. So when we're given, that's why in our escalating airway algorithm, we set goals. We want and you'll see this when you watch those videos, but we set a goal of 94% or greater oxygen saturation by the least amount possible. So we start basic until the patient proves that they cannot live with what the basic maneuver is giving. So we start with the nasal cannula. Now, keep in mind, we did give ranges. We discussed ranges in here just a little bit ago about if you need high flow oxygen after a certain range, you should have from 91 to 94 is mild hypoxia. That we should have. Here, let's go. Let's do this. There we go. So here's our normal range: 95 to 100, or 94 or greater is normal. We need to change our FiO2, or how much O2 they're inhaling, to maintain this saturation. So if they're maintaining 95 to 100 on their own, we don't need to do anything to it. If they're 91 to 94, we're in mild hypoxemia. We need to increase our FiO2 or give them supplemental oxygen to help bring that back up to over 95. Now, the only exception to this is going to be our COPD patients, or our where they're in that hypoxic drive that we discussed earlier. So we will allow a permissive hypoxia, if you will, and we want to maintain them around 90. So that shifts just a little bit. This is indicating normal, whereas that would be an abnormal state with the hypoxic drive. So 86 to 90, this is where the book suggests running a simple mask or a non-rebreather, especially for 85 and less. I've had, in personal experience, I have had patients in the 85 to 86 range that increased very well with nasal cannula, and did quite well with that. Every patient is individual. Every patient is different. As you gain experience, you will be able to judge this a little bit better on where to start. Sometimes you will not start with a nasal cannula. You may start at that simple face mask if you carry them, a partial non-rebreather or a non-rebreather, depending on what your service carries and how you intend to go that way. So moving on, we are going to talk about the pulse SpCO oximeters. Our devices, they detect abnormal hemoglobins, such as carboxyhemoglobin from carbon monoxide poisoning. The methylhemoglobin, as seen in methemoglobinemia. Some devices can also detect total hemoglobin. Until recently, these devices were only found in hospital labs and required blood sample. Recently, non-invasive CO oximeters have been developed and that will detect and measure carboxyhemoglobin in the same manner that standard pulse oximeters detect and report oxygen saturations. These devices may prove useful when screening patients with potential exposures or vague, unexplained symptoms. So some of your monitors, the LifePak 15s, I know if they have the right finger probe, they will read CO levels as well. I'm not sure if I don't have as much experience with the Zoll monitors, if they will do this or not. I just know the Physiology LifePak 15s do. Pulse CO oximeters use multiple wavelengths of light to detect various forms of hemoglobin found in humans. Like a pulse oximeter, they detect hemoglobin with oxygen bound. They'll oxyhemoglobin, hemoglobin without oxygen, or deoxyhemoglobin. Depending on the device, they can also detect the following: the carboxyhemoglobin when carbon monoxide is present, like we've discussed. It builds up. There is a there are 4 heme binding sites on each hemoglobin molecule. CO will displace oxygen molecules that are already present on the heme part of the hemoglobin, allowing the CO to bind and form carboxyhemoglobin. As these molecules are bound with CO, the oxygen carrying capability or capacity of the hemoglobin is greatly reduced. Pulse CO oximeters can detect increased carboxyhemoglobin. The amount of carboxyhemoglobin detected is reported as a percentage of total hemoglobin and is abbreviated as SpCO. Methemoglobin is a form of hemoglobin which the iron molecules in the heme units are in the ferric Fe3 state. Thus, methemoglobin can neither bind nor transport oxygen. Methemoglobin is a bluish brown color, normally where the enzyme systems methemoglobin reductase that can restore methemoglobin to the ferrous Fe2 state, forming dioxyhemoglobin so it can again transport oxygen. Typically, less than 2% of the hemoglobin in the body is in the form of methemoglobin, which cannot bind or transport oxygen, as we discussed. However, several conditions and drugs can cause abnormal elevations of methemoglobin resulting in methemoglobinemia. Selected pulse CO monitors can measure this and report its percentage as total hemoglobin, or SpMET. The total hemoglobin pulse CO oximetry now allows for a non-invasive measurement of this in the pre-hospital setting. This reading is reported as SpHb. This now allows for pre-hospital detection of anemia and blood loss and can serve as a surrogate indicator of the blood's oxygen carrying content, which that's huge. That is huge. Being able to have an actual quantitative judgment of the body's ability to transport oxygen can guide you so much better. However, we rely on our education and our experience to gain this knowledge as well. But if we can put a quantitative note to it, then we know exactly, because the only thing that's really going to help our patient is to increase that oxygen carrying capability. We can throw as much oxygen as we want at them. If the patient cannot carry it, then we're just adding oxygen to add oxygen. Non-invasive monitoring technology is evolving rapidly. Many of the parameters are available on many of the popular commercial patient monitors used in EMS. Like other technology, pre-hospital personnel should not solely rely on monitoring technology. Like I said, before this, we judged oxygen carrying capability by our assessments, by how much blood was on the floor, how much normal saline are we giving them? Are we giving them huge boluses? Because that's not to replace that blood that's on the ground, because normal saline does not carry oxygen. So we're not expanding oxygen carrying capability. We're only expanding volume to increase blood pressure to get what oxygen we can back to the tissues that need it. Instead, look at the entire patient picture, make the treatment decisions based on multiple findings and parameters. And this is where our total assessment comes in. Now, I know we were concentrating solely on respiratory, but this is the total patient assessment that we need to get to work with here. And this will only augment and enhance our assessments, but we need solid primary and secondary assessments to go along with these tools, and to make our differential diagnosis, to make our treatment plans, and to hone in on what this patient needs and how best to proceed.